Good afternoon and welcome to the USDA Human Nutrition Research Center on Aging's Monday Seminar Series. Before introducing today's speaker, let me remind you to ask your questions for our speaker using the Q&A icon located on the webinar toolbar. And you can do this anytime during the presentation. And please do not use the chat box for questions. Again, use the Q&A icon. Today's speaker is Dr. Ahmed Alhassani. Dr. Alhassani is an assistant professor in the Department of Periodontology at the Tufts University School of Dental Medicine, where he's involved in teaching, clinical practice, and research. He received his bachelor in dental medicine and surgery from King Abdulaziz University in Saudi Arabia, and then completed his certificate of advanced education in periodontology and a Master's of Science at Tufts University School of Dental Medicine. He earned his Doctor of Science in Nutritional Epidemiology from the Harvard T.H. Chan School of Public Health, where he focused on the connection between diet and periodontal disease. His current research explores the relationship between dietary intake, chronic illness, and the link between oral health and overall health. And he'll discuss that today in this presentation titled The Association Between Dietary Intake and Periodontal Disease. And now let me turn the microphone over to Dr. Alhassani.
Okay, thank you so much, Dr. Jacques, for the introduction. And I would like to thank the HNRCA for the invitation. And I really appreciate everyone being here. And I hope you find it interesting and educational. This topic is very close to my heart because it brings my two worlds together, being a periodontist and being in nutrition epidemiology. And it's the association between dietary intake and periodontal disease. We're talking about the association between nutrition intake and periodontal health. So let's take a look at the mouth, and let's actually take a closer look. So it turns out that we know much about the impact of nutrition and diet on the health of teeth. We know that sugar intake, we know that highly processed carbs and sticky foods are bad for the teeth because they cause tooth caries and everything. However, we don't know much about the impact of diet on the tooth supporting structure, the gingiva, the alveolar bone, and the rest of the periodontal tissue. And I find this very interesting, considering that one of the earliest discoveries, one of the seminal discoveries in nutrition epidemiology was the relationship between scurvy and citrus fruits. And scurvy, one of the symptoms of it is severe forms of gingival health that could lead to tooth loss. So it is interesting. So this is what a fairly healthy gingiva would look like. There are no signs of inflammation of attachment loss. And if you take a cross section on this lower tooth, for example, this is the structure. This is the tooth structure. This is the roots. And this is the gingival tissue, the alveolar bone, and the periodontal ligaments. And it's really crucial and important to differentiate between two things, gingivitis and periodontitis. So gingivitis is a reversible thing. I don't brush my teeth for a few days. I will develop some signs of inflammation, bleeding, swelling, okay? But all of that is reversible. However, in a susceptible host, on a susceptible site, this gingivitis would turn into periodontitis with attachment loss that can present itself as recession or periodontal pocketing, and both of those would lead to reduction in the tooth supporting structure and making the tooth weaker. And we do measure this clinically through periodontal probing, okay? So for each patient, a dentist or a periodontist would take the readings, fill a periodontal chart, and based on that, we make a periodontal diagnosis. And we actually do, or at least we think we do, that we can accurately diagnose periodontal disease on a clinical case, on a patient-by-patient case. And as you can see here, we do have a good platform for diagnosing periodontal disease. As you can see here, the last classification was fairly recently. It was in 2018, where we updated the platform for diagnosing periodontal disease. However, unfortunately, when it comes to epidemiological study, we don't really have a good consensus on how to define a periodontitis case. And this is something that I will get back to during the presentation. So what's the pathogenesis of periodontitis? The pathogenesis of periodontitis, and I want to just make sure that in this presentation, and like mainly when I say periodontitis and periodontal disease, I mean the same thing, okay? So periodontitis, periodontal disease, they're the same. So the process entails the microbial challenge through the colonization of periodontal pathogenic bacteria. And we like to talk about the red complex, the P. gingivalis, the T. forsythia, and the T. denticola. And this microbial challenge is essential, okay? After that, is essential for the development of periodontal disease. However, there is substantial evidence that most of the destruction occurs through the host response. And the host response entails inflammatory mediators such as tuber necrosis factor alpha, interleukin 1, 6, and 8, and prostaglandin E2. So microbial challenge is essential, but most of the destruction is through the host response. So how common is this thing? It is actually quite common. And if you go to if you went to the American Academy of Periodontology in 2012, this was the homepage. And based on enhanced analysis, it was discovered that about half of the population in the US, 30 years or older, had at least some degree of periodontal disease. Okay. I have to say that this was the first time that NHAIS included a full mouth examination. Before that, it used to be based on partial mouth examination, which actually kind of severely underestimated the disease. So that was groundbreaking. So it is quite common. Continuing talking about the epidemiology of periodontitis, the risk factors are age, older age, male gender, some races and ethnicities, and that depends on where you study it. So non-Hispanic Black tend to have higher risk of periodontal disease. The disease has genetic components. Low socioeconomic status is associated with the higher prevalence of periodontal disease. Diabetes, the relationship between diabetes and periodontal disease is complicated and it tends to be bidirectional. So on the right side, we have the modifiable risk factors. Smoking is actually one of the worst things that you can do to your gingival or periodontal health. It's the strongest environmental risk factor. Poor oral hygiene is associated with the higher degree of periodontal disease, obesity, low levels of physical activity, alcohol intake, and some aspects of diets, which is today's topic. Also, periodontitis as an exposure, it is associated with some systemic conditions such as CVD, preterm low birth weight, impaired glycemic control, and impaired cognitive functions. And when it comes to periodontitis and the general health, it seems that the connection is through systemic inflammation. And there is a plethora of reports about the association between periodontitis and systemic inflammation. So periodontitis would lead to systemic inflammation, and we have good evidence for that. The reverse, however, in the presence of systemic inflammation, does that increase the risk of periodontitis? That's actually not studied very well, and we're not really aware of it. Like, we're not really sure about that. Okay, so I want to talk about obesity and periodontal disease first, as it's very germane to today's topic. It was first reported in Japan about 26 years ago in the New England Journal of Medicine. And after that, it was a semi-consistent finding in most of the studies. So this is a meta-analysis of the cross-sectional studies, and obesity was associated with a higher risk of periodontal disease. And the same thing goes with longitudinal studies. So overweight associated with periodontal disease, being obese is even more strongly associated with periodontal disease. Okay? So what about today's topic, diet and periodontal disease? The evidence is kind of scarce. So This relationship is very biologically plausible, and some animal models did show this association. So change in diet would lead to breakdown of alveolar bone and periodontal and periodontal structure. Only a few human studies looked at certain aspects of diets. Most of them were cross-sectional studies at some longitudinal and clinical trials. Interestingly, most of the studies, they looked at nutrients that are essential for connective tissue health, such as calcium, vitamin D, and vitamin C, and also for other reasons, for one reason or another, they looked at omega-3 and omega-6. And there are only limited amount of studies that looked longitudinally at food groups and periodontal health. And I will talk about some of the relevant studies here. So Merchant et al. Looked at whole grain and fiber intake and periodontitis risk in men, and they found that whole grain intake was associated with a reduced risk of periodontal disease. Another publication from the Boston area, this was in the VA normative aging study, and they found that higher fiber food reduced the risk of periodontal disease in older men aged 65 and older. Yoshihara looked at the association between diet and oral health as a whole, so dental caries and periodontal disease, and they found that intake of vegetables was associated with low risk of periodontal disease, while intake of cereals, nuts, seeds, sugar, sweeteners, and candies were associated with a higher risk of periodontal disease. More recently, Yahoyanin found that poor diets were associated with higher high or deepening of periodontal pockets, okay? And they found that this association was strong among non-smokers, okay? So I would like to go ahead now and share our work in this area. So the first project was looking at the association between major dietary patterns and periodontitis, and we used principal component analysis for this study. So the hypothesis was that a Western diet would increase the risk of periodontal disease, while a prudent diet would reduce the risk of periodontal disease. And I'll explain what I mean by Western and prudent in a second. So the study population was a secondary analysis in the health professionals follow-up study, which was started in 1986. It included dentists, pharmacists, and other health professional men. So all the cohorts here were men. And they provided medical history, dental history, and body measurements and other behaviors and health-related conditions in biennial questionnaires, starting in 1986 until today. And every 4 years, they provided information about their diet through FFQs or food frequency questionnaires, they were validated against diet records. So this is just an example of the food frequency questionnaire where the participant shared information about their diet intake in the previous year. And those are semi-quantitative, so they include the quantity as well and the frequency. So we excluded participants who had periodontitis and those who were edentulous or had no teeth. They were not at risk of developing the disease, which is periodontitis. We excluded individuals with missing data on periodontal information, BMI, physical activity, and age. We also excluded those with contributory medical events such as myocardial infarction, coronary artery surgery, cancer, and diabetes, okay? And we also excluded participants who left about half of the FFQs empty, or those with caloric intake outside the plausible range for men, which is 800 to 4,200 a day. So the the final sample size was just shy of 35,000 individual. So for case assortment, the outcome of this study was self-reported periodontal disease, and It was measured in the questionnaire, the biennial questionnaire. So if the participant said that answered yes to the question, have you had periodontal disease with bone loss diagnosed, then they were considered a case. So once they say yes that they had this diagnosis in the past year, then we consider them a case. Okay, so it's self-reported, and this method of self-report in this cohort has been validated among dentists and non-dentists in the cohorts. It's worth mentioning that dentists, I think, are just about half of the population in this study were dentists, and you can see that the positive predictive value and the negative predictive value were acceptable for this cohort, the self-report. So we used principal component analysis. We had 40 food groups. They were entered into the principal component analysis, and two factors explained most of the variability in this study. And they were termed, the first factor was termed a prudent pattern, and the second factor was termed Western pattern. The prudent pattern was rich in vegetables, fruits, legumes, whole grains, fish, and poultry, while the Western pattern was rich in processed meats, red meats, butter, high fat dairy, eggs, and refined grains. For the statistical analysis, we used Cox proportional hazard model. We used Asian month as the time scale, and we calculated the person time from the baseline, 1986, until either an individual became a case, a periodontitis case, mortality, last available response, or the end of follow-up for this study, which was January 31st, 2010. And for the exposure, we did the analysis twice. So we first looked at the quintiles of food and diet patterns, and then the quintiles of Western diet pattern. We adjusted for smoking using the comprehensive smoking index. We adjusted for physical activity, for alcohol intake, occupation, dentist versus non-dentist, race, energy intake, BMI, and diabetes. So over the 24 years of follow-up, 3,738 new cases of periodontitis developed. And those are the characteristics of the study. So here are the quintiles of the Western diet, and here are the quintiles of the prudent diet, which is just magnifying the characteristics. And we can notice that individuals in the lower quintile of Western diet, they were older, they had lower BMI, and they had lower chance of being smokers, okay? And they were more physically active, and dentists here were most in the lower quintiles, okay? And the prudent was actually the opposite. So for the lower quintile, they were younger, they had higher BMI, and they had more chance of being smokers. So looking at the results from the Cox proportional hazard models, it turned out that the Western diet and the prudent diet, they were both they turned to null results. So model 1 was just age adjusted. Model 2 included all the covariates except the BMI, and model 3 included the BMI. Okay, and the results were null. After that, we just looked at the subgroups of the study, and we found null association all over the subgroup except for BMI and the Western diet. And I want to share this with you. So for the Western diet, we stratified by the BMI, 18.5 for like healthy, overweight, and obese. And we found a statistically significant interaction with obesity. And we found that those in the highest quintile of Western diet, they had a higher risk of periodontal disease, about 83% increase in the risk of periodontal disease. Okay, so that was the only group the obese individuals had a significantly higher risk of periodontal disease in the highest quintile of Western diet. Okay, so we went ahead and we looked at this using the joint association. So here are the quintiles of the Western diet, and this is the categories according to the BMI. So normal, overweight, and obese. And you can see that those who were obese with the highest quintile of in the highest quintile of Western diet, they had the higher risk of periodontal disease. And it's really interesting here because if you look at the obese, like all over the other quintiles, they seem to be doing fine, okay, except for this one. So that was interesting. And in trying to understand this, so our hypothesis was that we know that obesity is associated with a meta-inflammation or a low grade of systemic inflammation, okay? And we also know that a Western diet has been associated with increase in systemic inflammation, and this increase in systemic inflammation seems to be there even with adjusting for BMI, and this relationship has been shown in different in different cohorts, in different populations. Okay, so we thought that maybe the concomitant impact of a Western diet, the systemic inflammation of the Western diet in already obese with the higher degree of inflammation, maybe that led to increase in periodontal risk. So for conclusion of this part, overall, there was no association between neither Western or prudent diet. Among obese, there was a statistically significant association, okay? So the mechanism, as I mentioned, it could be due to systemic inflammation, but we cannot also disregard other mechanism. It could be due to insulin resistance. We know that obesity is associated with insulin resistance, and insulin resistance might be the cause here. Maybe you have some undiagnosed pre-diabetes or diabetes in the cohorts, and the relationship between diabetes and uh, and periodontal disease is strong. However, we did adjust for diabetes in different ways. We included in the model, we excluded it from the model. We also censored individuals if they developed diabetes. We did the analysis, not including diabetics, and the results were similar and they were robust. So it could be due to systemic inflammation, but we cannot really be sure. So that project led to the next project, which is looking at the inflammatory impact of diet and the incidence of periodontal disease. So the hypothesis here was that inflammatory diet would increase the risk of periodontal disease. And here we used a reduced rank regression, or RRR, which to develop the index. So in any exposure leads to an outcome, and usually that entails some intermediate variables. So the beauty of RRR is that its goal is to maximally predict or maximally explore the variability in the intermediate variables. And once that index is developed, you can go ahead and check whether this exposure or this index is related to the outcome. So in this study, or like in this project, we're looking whether diet through the inflammatory mediators, whether diet through the increase in inflammatory mediators would lead to periodontitis. So RRR is really good in exploring causality. So here we use the empirical dietary inflammatory pattern developed by Tabong et al. And it was developed in the Nurses Health Study, and it was validated in the Nurses 2 and the Health Professional Follow-up Study, which is the cohort we're working on. So in developing this index, 39 food groups used RRR to maximally explain the variability in interleukin 6, CRP, and tumor necrosis factor alpha receptor 2. And So that one factor was extracted and it explained most of the variability in the inflammatory mediators. Then stepwise, the linear regression led to 18 food groups. 9 of them were pro-inflammatory and 9 of them were anti-inflammatory. And ADIP is a weighted average of those food groups. So the pro-inflammatory foods were fish other than dark meat, tomatoes, processed meats, high energy beverages, vegetables other than leafy greens and dark yellow, red meats, low energy beverages, refined grains, and organ meats. The anti-inflammatory diets were pizza, wine, leafy green vegetables, dark yellow vegetables, beer, coffee, fruit juice, snacks, and tea. Okay. So this might be actually counterintuitive for some of the food groups, and we can talk about it later. But this is an empirical index, and those are the foods that were associated with the inflammatory mediators. We used also Cox proportional hazard models. The time scale was age, okay, and we also calculated the person time the same way until peridontitis, mortality, last available response, or the end of follow-up. And we used quintiles of the ADEP score as the main exposure. We used the same covariates to control or adjust for the analysis. Same number of cases, 3,738 over the 24-year of follow-up. So this is the basic characteristic of the study population. Looking deeper, we can see that individuals in the lower quintile of ADEP, they tended to be smokers. They tended to have more alcohol consumption, which is not surprising as alcohol is a part of ADEP, and they tended to be more physically active. Okay. The results of the models here, they were null. Again, we used the same thing. Model 1 was age adjusted. Model 2 was fully adjusted except for BMI, and Model 3 was adjusted including BMI as well. The results were null, so we went ahead and we looked at the association in the subgroups. The association was null overall. However, we noticed that, so in this study, we just categorized the BMI into obese and non-obese. We noticed that there was a marginally statistically significant interaction between obesity and with obesity. So, and the results were just marginally significant. So we went ahead and looked at the subgroup of obese who were not smokers at the baseline. And we did find some significant association. So in the highest quintile, in the quintile 4, the risk was 45% higher risk of periodontal disease, and it was slightly lower in quintile 5. Okay, so it was about 40% increase in the risk of periodontal disease, only looking at this subgroup of a subgroup, which is obese non-smokers. So the thinking here was that probably smoking is a strong risk factor, especially in this cohort. Okay, so maybe smoking would trump the effect of any good diet or bad diet, but it's still, this is again like, we're aware that it was a subgroup of a subgroup. However, looking at the joint classifications, though this is everyone here, okay, obese and non-obese. And there was a statistically significant increase among obese with higher scores of ADIP or inflammatory diet. Looking at the non-smokers, the association was stronger. So overall, there was no association between inflammatory diet and incidence of periodontal disease, only among obese non-smokers. So it could be due to systemic inflammation, okay? But also we cannot really disregard other mechanisms. EDIP is associated with diabetes, but we also try to control for diabetes in different ways, but still the results were robust. So looking at something a little bit more positive here, and looking at the impact of dietary flavonoids on the intake or habitual dietary flavonoid intake and the risk of periodontitis. So the hypothesis was that flavonoid intake would reduce the risk of periodontal disease. So flavonoids are naturally occurring pigments. They are available in fruits and beverages. So they're in fruits, vegetables, tea and fruit juices, coffee and red wine. And there's no shortage of basic studies and some intervention studies for the potential impact or like a promising potential impact of flavonoids on the health of the periodontal tissue. However, there was not really a study about habitual intake and the risk of periodontal disease. So in this cohort, still the health professional follow-up study, we looked at total flavonoid intake, okay? And we looked at flavonoid subclasses. So we looked at those 6 subclasses. We did not look at isoflavones because of the lower intake. It's mainly soy. It comes from soy and tofu and stuff like this. And this cohort, the consumption of isoflavone was low, so we could not really investigate isoflavone. So the same methods we use Cox proportional hazard model and the same person time. The exposure, we first looked at total flavonoid intake, and we looked also at the 6 subclasses here. We adjusted for the alternative healthy index, healthy eating index without the fruits and vegetables. Smoking, physical activity, alcohol intake, occupation, again, dentist, non-dentist, race, energy intake, BMI, and diabetes. The same number of cases over the 24 years of follow-up. And this is the basic characteristic of the study. You can see that individuals with lower intake of flavonoid, they tended to be smokers. They tended to have lower levels of physical activity, and naturally they had more fruits and vegetables intake. So overall, the association between total flavonoids and flavonoid subclasses was null. However, it was really surprising to see that flavonols had actually a harmful effect or a harmful impact on periodontal health. So in the adjusted model, you can see that the fourth quintile had a statistically significant increase, like 16% in periodontal disease. Okay, so and almost the same for the quintile 5. So that was surprising and unexpected. So we looked at food-based analysis, and we looked at flavanol sources in this data. So it could be, so the main sources of flavanol were tea, apples, onion as garnish, and onion as a vegetable. And we also looked at the main sources of total flavonoids in this cohort, which were tea and apple, or orange juice, oranges, strawberries, blueberries, and red wine. So we did the food-based analysis, and it turns out that onion, especially as a garnish, was actually like relatively strongly associated with higher risk of periodontal disease. Okay. And when we entered onion to the model, the association between flavanol and periodontal disease disappeared. So it could be mainly to onion as garnish. Okay. And also there was some association between red wine intake and high risk of periodontal disease, even after controlling for alcohol. So there's something with red wine here. So, however, we have to take those findings with a grain of salt, because it could be due to chance. There's nothing really about onion that could explain why it is like that. could be due to the way it is consumed. So as a garnish, it might be something in burger or like, any processed foods. It can be can be associated with certain behaviors as well, or the way of cooking, but yeah. So our food analysis based analysis led to these findings, but overall the association was no. So for these three projects, it has the strengths and limitations of any large cohorts. So there was some information bias, of course, especially that everything was self-reported. However, we used the cumulative average of the intake of foods, and the outcome was validated in this cohort. Uh, generalizability is questionable because this is a cohort of male and mainly white, highly educated, higher socioeconomic status. Just like any observational study, compounding cannot be ruled out. But it is a large cohort. It's it was prospective in nature, and to date, I think it's the biggest cohort with the largest follow-up time that investigated the association between diet and periodontal disease. So overall conclusions, not unlike many projects, you come out with more questions than the ones you started with. For public health and clinical individual care, we don't really have a lot of evidence that nutrition does impact the overall health, but it does impact we don't really have a lot of evidence that diet does impact the periodontal health, but we have a lot of evidence that it impacts the overall health. So future direction, we should look at other populations, other dietary indices, food-based analysis, and timing of exposure as well, and when is the time that is critical to development of periodontal disease. Also, it's very important here. So I talked earlier about the definition of a case in epidemiologic studies and how we don't really have a consensus on what really determines a case. In this case, it was self-reported, which actually tends to tends to focus on most severe cases. The deleterious or the beneficial effects of diet could be, like the impact of diet could be at a lower scale. So like it might be on a continuum. So maybe less probe in depth or like more attachment loss. So this is something that we have to look at. So so it is really important to talk about periodontitis case definitions. And this topic was really interesting to me. So in this project, we looked at the influence of periodontitis case definition on the association between periodontal disease and glycemic status. So for this project, we just looked at on how a case is defined using the same individual and how in the same individuals in the same cohort, but we just used different case definitions and how that impacted the association. And actually, the results were really interesting. That it was significant. So for this, I just want to show the table one of that project, which is just looking at the prevalence and how it differs significantly. So the total CDC, like AAP, this is the definition, which actually very close to becoming the gold standard for epidemiologic studies, but not yet. So this definition was developed by the CDC and the American Academy of Periodontology. And I wanted to look here at the prevalences. Again, this is the same cohorts. This is like enhanced data, just using different definitions that have been used in the literature. And you can see that in some definitions, the prevalence is up to like close to 70%. In some of them, it's like 8 or 7%. Another interesting thing is that if you look at the CDC AIP, which is again very close to be the gold standard for epidemiological studies, and self-reported, they were almost the same, which I think it was kind of interesting here. So also, I we can also look at periodontal disease at other, I mentioned this before, but I think it's really interesting. I mean, I'm not going to try to hide my bias here, but periodontal disease and the association with systemic it is an interesting topic. We can investigate a lot, and it seems to me that that's association, especially with impaired cognitive function, is a hot topic nowadays. It was really the last academy meeting was in November last year. They were talking about a lot about the association between periodontitis and impaired cognitive function, especially with the fact that we know that the bacteria such as P. gingivalis has been isolated in the brains of Alzheimer patients. So that is interesting. So would like to thank you all for being here, and I welcome your questions.
Thank you very much for that very interesting presentation. We have a couple of questions already, so let me start off with the first question, which comes in from Michael Lustgarten. And he asks, when considering that an acidic oral pH impacts caries risk, have you evaluated associations for dietary acid load with periodontitis risk?
Oh, the answer is no, but it can be interesting. I like at the top of my head, I don't think it would be related, the acidic environment and the periodontal health, but it could, but it, like I did not investigate that, no.
Second question comes in from Larissa Constantinou, and she asks, have you explored how periodontal disease affects the composition of consumed diet and thereby health?
Okay, so so there are some published literature about the impact of periodontal disease on and there's actually like cross-sectional and longitudinal studies as well, in which with periodontal disease, especially with the loss of teeth, people tend to change their diet into more processed and more and less healthy foods.
Okay, we're waiting for the questions to come in. I actually have a question.
Sure.
You mentioned the obviously the bacteria are critical to for periodontal disease. But does the oral microbiome actually include any bacteria that may be beneficial or protective against uh, periodontal disease? And if so, is there any evidence that diet might affect the oral microbiome?
That is very interesting. And yes, the answer is yes. So if we look here, okay, so the first bacteria that actually develops, they are non-pathogenic, okay, so like they're always going to be a dental plaque or oral microbiome, okay. So the first bacteria are non-pathogenic, and then after that, the pathogenic bacteria and the anaerobic bacteria would develop. So the answer is yes, but with the accumulation of bacteria, then it comes the pathogenic or like anaerobic bacteria. The other thing is there are some reports now about oral microbiome, how it could be actually the mechanism for diet and periodontal disease. I think I read something about the association between oral microbiome and intestinal microbiome on that, how that could be like in the pathway. But also another thing was I found, I think, one cross-sectional study that looked at the probiotics intakes, and they found a less risk with periodontal disease. But yeah, so it's still out there.
Okay. Let me see. There's no other questions in the queue. I'll wait just a few seconds here to see if any other questions arise. And seeing none, I want to again thank you for a very fascinating presentation. And thank you again for being with us today.
Thank you so much.
Bye.
Bye.
Okay. Nice presentation.
Thank you.
Yeah, it's an interesting topic.